Good afternoon, delegates attending the International Physiotherapy E-Conference, Quadrans 2021. I am Barry Getz from South Africa. I'm a practicing physiotherapist in the orthopedic and sports medicine realm. I've been given an absolute honor and privilege from the Kahir Institute of Physiotherapy in Belgavi, India, to present a short topic on the subgluteal space. Unfortunately, I can't present this live as the COVID pandemic has been both trying to everyone here in South Africa, and I am scheduled to see patients at this time. Hopefully in the near future we'll be able to interact over a live Zoom call where we can answer all your questions, but I'm sure as the Kahir Institute of Physiotherapy has arranged such a spectacular talk and conference, they will forward any questions that anyone may have so I can answer them at a later stage. Thank you. I hope you enjoy the talk. Please stay safe and all the best for the future. Good evening, everyone. I'm Barry Getz, a physiotherapist here at the Center for Sports Medicine and Orthopedics and at the Linksfield Orthopedic and Sports Rehab Center. Let's talk a bit about the subgluteal space and what we can rehabilitate. But before we begin, let's define this area, what we talk about. What is the subgluteal space? Well, it is the cellular and the fatty tissue located between the middle and the deep gluteal aponeurosis layers. Posteriorly, it's defined by the gluteus maximus, and that moves all the way anteriorly to the posterior acetabular column, the hip capsule, and the proximal femur. Laterally, you have the lateral lip of linea aspera and the gluteal tuberosity. Medially, you have the sacrotuberous ligament and the falciform fascia. Superiorly is the inferior margin of the sciatic notch, and inferiorly you have the proximal origin of the hamstrings and the ischial tuberosity. So what is so important about this space? Well, defined by this space, we have a fairly large structure, the largest nerve of the human body, the sciatic nerve. And that sciatic nerve has an excursion of about 28 millimeters as it moves through that space as we're moving through hip flexion. And that was shown by Kopitias et al. In 2006, where they did a vast number of tests with straight leg raising, and they measured this on cadavers. But that importance of that subgluteal space is not just a pain in the behind or a pain in the donkey, as we say, because there are multiple causes that can result in that pain. And those are both intra and extra-articular in nature. And to best understand this, we're going to use a 5-level approach, or I use a 5-level approach, so we don't miss diagnoses as we're going through our clinical testing, both subjective or even objective testing. So these are your osseous, your neurovascular, your musculotendinous, your capsulolabral or ligamentous, and then your kinematic chain. And this was described by Hal Martin. So let's look at the osseous layer and how we would look at definitions or problems in that area. So we can move across right from the sacroiliac joint to the posterior acetabular wall, the greater trochanter, lesser trochanter, so on and so forth. And these are just to mention a few of those osseous structures that may cause posterior buttock pain, but just straight buttock pain. If we move into the neurovascular layer, we start talking about inferior gluteal arteries, sciatic nerves, the branches of those sciatic nerves, and even the fibrovascular band or the leash that can encase the nerve and can cause compression. When we move into the musculotendinous layer, we start to look at a whole heap of muscles that can influence not only the nerves in the area, but can also be traumatized due to bony architecture. And we'll look at things like gluteus medius, piriformis, the tendons. We can even go as far as to say, well, what happens anteriorly with the groin, as an example, or the origin of the adductor muscles. Do they refer to the posterior hip, or are they often misdiagnosed or confused with buttock pain? If we move into the capsulolabral or the ligamentous structure, well, anteriorly you have Bigelow's Y ligament, which is made up of the iliofemoral and the pubofemoral ligament, your strongest ligaments of the hip. Posterior is that ischiofemoral ligament. Moving intra-articularly, you're looking at labral tears. You can even look at paralabral cysts, ligamentum teres, or even synovial disease like pigmented venonodular synovitis or synovial chondromatosis. All of these structures have some sort of referral pattern to the buttock. So don't forget about them. And then finally, let's look at the kinematic chain. So what are we talking about in this regard? We're talking about how the mechanics above or below the hip joint can influence it. So top-down mechanics versus bottom-up mechanics. And these 5-layer approaches all have their own tests. And we can't go through all of them tonight. We have 30 minutes. We're going to focus on one specific condition, and that is called deep gluteal syndrome, or the infamous or forgotten deep gluteal syndrome. And I'm going to make very specific reference on the syndrome as to how the sciatic nerve may be influenced or entrapped as we track the anatomy down the sciatic nerve. Please remember there are differential diagnoses as well, and we've mentioned a few of them in our previous slides. So what are the symptoms that we see for deep gluteal syndrome? Well, first of all, this deep gluteal syndrome is an underdiagnosed entity, which is characterized by pain and or paresthesia in the buttock or posterior thigh. And you can get radicular pain due to non-discogenic sciatic nerve entrapment in the subgluteal space. Patients often complain of pain with sitting, and it is progressive in nature, unfortunately. And there are other pathologies that can mimic this, those being the hamstrings or the intra-articular hip pathologies. So let's start with Piriformis syndrome. So as the sciatic nerve travels down and enters the level of the piriformis, we have a muscle, the piriformis muscle, which takes origin from the anterior surface of the sacrum, where it starts between the sacral foramen and the sacrotuberous ligaments, and it moves laterally to the greater trochanter. And you can get hypertrophy of that muscle. You can land up getting asymmetric enlargement that will displace the sciatic nerve, and that can also create a dynamic entrapment of the sciatic nerve. But also you may get pathways of how the sciatic nerve moves around through or in between the piriformis muscle. Of interest is, as the piriformis muscle moves laterally, it has an association to the posterior capsule of the hip. So any inflammatory-based condition of the capsule of the hip mimics a piriformis syndrome. But what's important to note is this deep gluteal syndrome is not always piriformis syndrome, as it is a subdiagnosis of that condition. If we move into the variant branches of the sciatic nerve with the piriformis, we can go back as far as 1938, when different dissections revealed anatomic variations of how the sciatic nerve moves around through, underneath, or above that piriformis muscle. And this was rewritten back in 1947 by Robinson, who notarized that, and you can see that in the picture on the right. If we start to talk about the nerve as it's moved caudally from the piriformis muscle, it will pass under the belly of that piriformis, or through or over, and then it will move over the superior gemelli and obturator internus muscle that acts like a scissors almost, and it will entrap that sciatic nerve in between those muscles, causing pain as well. So bearing in mind, again, we're still talking posterior buttock pain. As we move more caudally, we're moving more into this ischiofemoral space, which is also an underdiagnosed space. So what do we know about it? Well, we know in males, through a multitude of studies, that we're looking for about 23 millimeters of space if we're doing CT investigation, and we measure that space, and it has a variance of about 7 mils. If we're looking at females, you're looking at about 18 millimeters, give or take 8 millimeters of variance there as well. But we know it's an under-recognized form of atypical extra-articular hip impingement, defined by hip pain related to the narrowing of that space between the ischial tuberosity and that of the femur. Narrowing of that ischiofemoral space will lead to muscular, tendon, or neural changes, creating that pain. And patients will present with mild to moderate and have non-specific pain in that deep gluteal region. Pain is usually chronic in nature and is gradually increases throughout the day. Pain can also be located lateral to the ischium on palpation and can go as far as the groin, which is more the adductor zone, or in the center of the buttock. Patients complain of a limited time for sitting, and they have a limitation of physical activities with specific emphasis on their stride length. The longer their stride length, the more pain they experience. And their symptoms vary between months or even years, with even no precipitating injuries causing this. As I say, it is an underdiagnosed entity, so often missed. If we go further down the pathway to that of the ischium and we're looking at hamstrings, the hamstrings take origin off the ischium. And what we can see, if you look at the dissection on the right picture versus the illustration on the left, your semimembranosus and biceps femoris attached to the ischium via the conjoint tendon medially on that ischium, and laterally you'll have the semimembranosus attaching. Of importance, just to have a look at the picture on the screen, the sciatic nerve moves laterally to these structures, and then you still have your posterior femoral cutaneous nerve that passes underneath those muscles. So any proximal pathology of those hamstrings mimic buttock pain, or are a form of buttock pain for that fashion. But what's important is they can get a radiating pain down the proximal part of their posterior thigh. The characteristics of this deep gluteal syndrome, or pain in the behind, well, it's as simple as that. It's buttock pain. You can have tenderness in the gluteal area or in the retrotrochanteric region, which is a sciatic-like pain. It's often unilateral, but may occur bilaterally, and it's exacerbated with rotation of the hip, and we see that especially when we flex the hip and extend the knee as it tractions those nervous structures. Patients have an intolerance for sitting, usually about 20 to 30 minutes. They have some sort of antalgic limp as they move around, and they can have a disturbed or loss of sensation in that affected extremity. They complain of night pain and or back pain, which is usually better during the day. And when sitting, they usually have some sort of antalgic sit to offload that buttock region. If we look at the characteristics of the nerves, well, I've put it neatly into a nice little table so you can see that. Just of emphasis, just look at the sensory components of the posterior femoral cutaneous nerve, how it gives you, it can be aesthesia or decreased sensation in the gluteal region, in the perineum, posterior thigh, the popliteal area. And look at the sciatic nerve, how that relates more to the leg and the foot, but it's not the saphenous nerve in that case. If we move into the examination of this area, now it gets a bit more tricky because we're going to throw a whole heap of tests at this problem to help us diagnose posterior gluteal syndrome. So I've put a few up there on the screen. So your straight leg raise or your SEG sign, your pace, your Freiburg signs, your Betty's maneuvers, your fair tests, and then your seated and your active piriformis stretches. Of importance to note is look at the fact that it's got a 91% sensitivity and 80% specificity to that of endoscopic findings. So those are very good tests to use. And then again, just bear in mind there are things like ischiofemoral impingement that you've got to make specific testing for, and all your hamstring syndromes. So what is a hamstring syndrome? Just before you all ask me, that's pain in your lower buttock that radiates down that posterior thigh to the popliteal fossa. and it's associated with weakness of that hamstring. Those patients also have pain with sitting and stretching, and especially exercising, more specifically the running drills. When you palpate that proximal part of that hamstring, they'll have tenderness around that ischial tuberosity and even that myotendinous junction. And then we'll have specific hamstring tests that we'll talk about later, being the 30 and the 90-degree resisted movements. But please also consider the sacroiliac joint of a source of pathology in this case, and that could be your cluster van der Werf, as published in 2006, just to assess the SI joint. It's another little contentious joint within sports medicine. Does it move? Does it not move? But here we'll do the Faber test, a distraction, a compression, and the Gaislin tests. Let's go into more detail about each test. So the straight leg raise test is patient is positioned supine. The examiner will lift the leg, keep the knee extended, and you're looking for pain in the buttocks. That would be a positive sign in that regard. If you look at the pace sign, the patient sitting over the side of the bed, they'll experience pain or weakness with resisted abduction or external rotation. And just bear in mind, if it is a true Piriformis syndrome, it occurs in a little under, or it's positive in a little under 50% of patients. The Freiberg's test, the picture in your top right corner there, the patient has pain and or weakness on passive forced internal rotation of the leg. Why does that occur? Well, perhaps that's stretching of the piriformis muscle, or it's pressure placed on the sciatic nerve at the sacrospinous ligament. If we look at the FAIR test, which is very similar to our FADEER tests, when we're looking for anterior hip pathology, you get painful flexion, adduction, internal rotation, and it's pain on that test. The Betty's maneuver, it's an active test that involves elevation of a flexed leg on the painful side. So what happens is the patient will lie on the asymptomatic side. They will then abduct that leg, or that symptomatic leg, the leg facing the roof, which will cause a deep buttock pain in patients who have Piriformis syndrome. But in your back patients, where the pathology is originating from the lumbar spine, the patient will complain of leg pain rather. Moving on to those sensitive tests that we mentioned earlier, the seated piriformis stretch. So whilst palpating 1 centimeter lateral to the ischium and towards the sciatic notch area, the patient will move their leg into extension, and the examiner will actively adduct and internally rotate that leg and will reproduce their buttock pain. Whereas with the active piriformis stretch, the symptomatic side faces the roof, asymptomatic side is on the bed, so the patient is side lying. You'll palpate the piriformis muscle with your one hand. The patient will drive their heel into the bed and they will abduct and externally rotate their leg, resulting in pain. I said please take note to the hamstring and the ischiofemoral impingement test. So for the ischiofemoral impingement test, very, very similar to that of the active piriformis test, you're going to palpate the ischiofemoral space with your finger, and you're going to extend that leg, and that can be either in abduction or in a neutral position, and that will reproduce a pain in that specific region. So I mentioned earlier where you got to put your fingers. Again, like most tests, practice makes perfect here. And Hal Martin described exactly where you want to put your index finger, your middle finger, and your ring finger to actually feel things like hamstrings versus sciatic nerve versus piriformis or even pudendal nerve. If we look at the active hamstrings test, patient is positioned in a seated position, and they'll actively flex their knee against resistance at 90 degrees. They'll have normal strength without pain if everything's okay, and they'll do that again at 30 degrees. And they may experience weakness, or they might recreate the symptoms in those positions, and that would be regarded as a positive test. As a variation, I do that in prone as well. Again, I find it easier to palpate, and I'll do it at a 0, a 90, and a 30-degree position, always palpating what's happening at that hamstring level. You can also do a bridge test, but with the patient off their elbows instead of lying supine in that position. But as I said early on, I'm a physiotherapist, so let's get on to how we treat this condition. So treatment consists of a 5-stage process. There must be an initial period of rest. Let's allow the inflammatory process to settle a bit. That will vary from days to weeks. We, or the doctors, let's say, would use a course of non-steroidal anti-inflammatory drugs in conjunction with that rest. Patient would then start a course of 6 weeks of physiotherapy treatment, and again that can be in conjunction with the non-steroidal anti-inflammatory drugs. We can then get onto our big interventional scenarios like infiltration of that space with local anesthetic, or even cortisone-based medication. And lastly, then you get your surgical techniques or your endoscopies to either release or retract tissue, or even perform some sort of osteoplasty in that area to create more space. So let's talk about the physio treatment. Our first port of call is let's correct the biomechanics, starting at the lumbar pelvic segment. And we can use a multitude of different techniques. Myofascial releasing, your muscular stretching, your joint mobs. But the idea is to correct that biomechanics. Let's neutralize what's happening. And your main aim is the decreasing of pain, and you want to re-establish that muscle length and muscle activation in that region. Balance is everything across the hip joint, and that is flexion to extension, abduction to adduction. One of the mentioned home exercises that we can use, and this was specifically in an article in 2016, as noted below, was the piriformis stretch, where the patient was in a seated position, they crossed their leg over, or the symptomatic leg crossed over the non-symptomatic, and they pulled that knee to the contralateral shoulder. And then the duration and the quantity of the stretch was determined according to the level of the healing process. We can also do mobilizations of the nerve. So this is a circumductory movement where you maximally externally rotate the leg and flex that hip, and then you pass that leg to your midline medially and then bring it back down into its rest position. And this is pretty important in the view of mobilizing the sciatic nerve, getting that excursion of that nerve as we mentioned before. Education is a crucial part in posterior buttock pain. What's the point of treating a problem if the patient keeps on reproducing their pain? So we want to educate the patient about repetitive motions and avoiding repeated positions that cause the pain. So positions of overstretching those external rotators can lead to weakness, which results in neuromuscular deactivation. And we've also seen that other complications related to these positions could be the increased strain of the sciatic nerve, as we've seen in some biomechanical cadaveric studies that have been published. Postural dysfunction is a massive component when it comes to hips, not just posterior buttock pain. Here I'm just mentioning the lower cross syndrome as mentioned by Dr. Janda. So a critical role to note in this is that the muscular activation of those lumbar pelvic stabilizers, the alignment of the lower extremity and its function, that all influences that hip. So through decreasing things like back pain with lumbar pelvic stabilization, you can improve neuromuscular control and pain associated with movement syndromes of the lower extremities. So again, take a moment, describe this to your patients. So whatever work you put in is not undone when they go home. Neural mobilization is very important. So we want to restore those compressive, tensile, and friction loads during normal kinematic movement of the hip. So we're going to use a glider and a slider technique. So whenever you are flexing the proximal part of the kinetic chain up by the head, you are plantar flexing the foot, so you're offloading that nerve. So again, we're wanting to promote an excursion of the nerves throughout the body. When it comes into strengthening of the leg, now there's a multitude again of what we want to do. An example of this is if we have a weak gluteal muscle, gluteus medius and minimus specifically, we see there's a related stiffness of the tensor fasciolata and sometimes even the iliotibial band, which results in that internal rotation of that lower extremity. So by simple strengthening of the hip abductors, the external rotators, those deep rotators, and all the extensors, we can get an improved proprioception to reestablish correct movement. And here we get pretty creative. But as I say, our aim is to bring awareness of what is deep gluteal syndrome and how we get about there. So I want to conclude from what I regard as a famous slide from a colleague of mine, Cara Lewis from Boston University. And this is what she said. She says, physiotherapists can't achieve a few things. So what can't we achieve? We can't change existing bone structures. We can't improve range, which is limited by bony impingements. We cannot reduce acetabular-labral tears, regardless of how we think we are, how good we are. And mechanical problems that require mechanical solutions we just cannot achieve either. But what can we do? Well, that's simple. We can change movement patterns of our patients. We can improve their arthrokinematics. We can reduce joint stresses, which thereby help those labral tears in healing. And a movement problem sometimes requires a movement solution to reduce those stresses. And I hope this has just broadened your perspective on what is posterior gluteal syndrome or deep gluteal syndrome. And you'll regard it next time you're looking, and don't just blame the old faithful piriformis muscle. Thank you for your attention.